Assalamu alaikum warahmatullahi wabarakatuh. Welcome to this lecture. My name is Fadi Tounsi. I'm an interventional radiologist and an assistant professor of radiology at King Abdulaziz University Hospital. So we're going to talk about interventional radiology. This is the outline of our lecture today. So interventional radiology as a specialty. It is the specialty of minimally invasive image-guided interventions. It's a new specialty in medicine. The diagnostic part was started in 1953 by Dr. Selninger. He is a Swedish radiologist and devised a system to puncture the femoral artery and be able to access the arteries percutaneously. This is Dr. Selninger, and it's well known nowadays as Selninger technique, which basically involves inserting a needle percutaneously into the vessel and then pulling back. So when you insert the needle, you would go through and through the anterior and the posterior vessel wall all the way until you hit bone, and then pulling back the needle until you get back flow of blood, and then inserting the wire, moving the needle out, and then advancing a catheter over the wire. A modified cylinder technique involves slight modification, so you wouldn't go through and through both the anterior and posterior walls of the vessel. You would just go through the anterior wall and then insert your wire and then remove the needle and then insert the catheter over the wire. All right, so the therapeutic part of interventional radiology was established in 1964 by Dr. Dotter. Dr. Dotter is considered the father of interventional radiology and actually got him a Nobel Prize nomination. This is him. This is an example case in which you can see some stenosis on the common femoral artery, and it was treated by introducing a catheter with good results. So as a specialty, it's a rapidly evolving specialty because it basically focuses on minimally invasive procedures. Everyone would love to get a low mortality and morbidity procedure instead of a big surgery that involves a long hospital stay. So in the 1960s, embolizations were introduced into interventional radiology to treat tumors and arteriovenous malformations. In the 1970s, embolization to treat massive GI bleeds. TIPS, which is a transjugular intrahepatic portosystemic shunt to treat variceal bleeding and refractory ascites in the 1990s. Endovascular aneurysm repair for abdominal aortic aneurysms, and radiofrequency ablation of varicose veins in the 1990s. Dates are not important, of course, for exam purposes. However, it just provides an idea about the advancement of the specialty. This is the interventional radiology suite. This is where an interventionist works. The patient would lie on the patient table, and this is the image intensifier. The X-ray source is just behind this physician here. The screen shows live fluoroscopy. Whenever the physician introduces a needle, they can see it, or whenever they inject contrast, they can see it. And this is the working table. You're more than welcome to visit the interventional radiology suite whenever time permits. So interventional radiology is a subspecialty of diagnostic radiology. It existed out of it. Currently, there are two main subtypes of interventional radiology, if we may say: body interventional radiology and neurointerventional radiology. Body interventional radiology involves 4 to 5 years of diagnostic radiology residency training, followed by 1 to 2 years of interventional radiology fellowship. Neurointerventional radiology again consists of the initial 4 to 5 years of diagnostic radiology training, followed by usually 1 to 2 years of neuroradiology, diagnostic neuroradiology fellowship training, then followed by 1 to 2 years of neurointerventional radiology fellowship. So it has a longer path to get into. However, it is considered a rare subspecialty, and there are not so many neurointerventional radiologists around. Interventional radiology is becoming an independent specialty nowadays. It is being separated from diagnostic radiology. So in the US, for example, one can apply for a combined DRIR training, residency training, that consists of 6 years of training. However, it was one of the most competitive specialties in 2017 and 18. So again, it's the specialty of image-guided interventions. So if you do interventions, you need to get proper patient information. The intervention radiologist would conduct a history and physical exam, and they would need to look at the lab investigations. They need to look at the prior imaging before the procedure, and then there's pre-procedure preparation, followed by procedure itself, then post-procedure care and a follow-up visit in the clinic or in the ward. So what I'm saying here is that it's not, it's quite different from what diagnostic radiologists do. It is a specialty that's more heading towards clinical work rather than diagnostic image-based work. So interventional radiologists do have clinics, and sometimes they can have admission under their own names. So this was about the interventional radiology as the specialty. Let's have a look at the different categories of interventions. There are different ways to categorize interventions in the specialty. So you can talk about arterial interventions, venous interventions, musculoskeletal, neuro, biopsies, etc. One convenient, acceptable theme with some overlap between different procedures is you can divide them into vascular interventions, percutaneous biopsies and drainages, embolizations, and interventional oncology. So these are the 5 main categories. Let's talk about them. First are vascular interventions. These can either be arterial interventions or venous interventions. And arterial interventions and venous interventions can either be arteriography or venography. So graphy is taking an image. It's just basically taking an image without doing any therapeutic intervention. So you wouldn't balloon or embolize or do anything other than taking an image. And then plasty is ballooning. So angioplasty, if you see a narrowing in a vessel, you can balloon it. Stenting is putting in a stent, which is da'ama in Arabic. It's like a small pipe that keeps the artery or the vein open. And sometimes you can also do thrombectomy. So if there is an embolus or a thrombus, you can basically remove it. This is an example renal angiogram. So have a look at it. This is the catheter here and denoting the anatomy of the kidney. This is an example in which the patient had a superficial femoral artery occlusion, long-standing, and the interventionist passed a wire and then angioplasty the vessel with good results at the end. This is the technique of how to angioplasty. Basically, you pass a wire through the atheroma and then angioplasty it and dilate the vessel. So that was about arterial interventions. Next are percutaneous biopsies. This is basically done to obtain tissue samples, and it can either be targeted to obtain a sample from a specific lesion, a mass in the liver, for example, or non-targeted to obtain a sample from an organ to assess the organ dysfunction. For example, a cirrhotic patient, and they want to assess the cirrhosis itself. So image guidance can either be ultrasound or can be done by CT scan or by fluoroscopy. Ultrasound gives an advantage of real-time imaging, so you see where your needle is while you're passing it. CT can bypass some of the limitations of ultrasound. Ultrasound doesn't penetrate gas or doesn't show beyond um, bone, so CT can show and bypass these limitations. Fluoroscopy also provides real-time imaging and shows bone, however it does not show soft tissue well. So you can use, the interventional radiologist would use different modalities at different times based on the lesion location and on the patient's anatomy. This is the mechanism of the biopsy. So a biopsy needle consists of two parts, the inner part and the outer part. This is the outer part, the two thin lines, and then the inner part. So once you fire it, the inner part shoots out, and then part of the tissue itself gets into the groove, and then automatically the outer part goes in, cutting part of the lesion itself and keeping it trapped within the groove. And then when you remove the needle, you'll have part of the lesion inside the groove. This is an example case. You're going to see the needle coming through here and then getting fired to take a biopsy of the kidney. This is the needle going in. No fire yet. And this is the needle getting fired. As you see, it's a quick movement. So like any other surgical procedure or interventional procedure, percutaneous biopsies can get complicated. Complications include vascular injury with subsequent bleeding, inadvertent organ injury, so injuring the colon while trying to get a liver biopsy, for example. And sometimes cancer can go through the tract in which the needle was inserted from. So prior to the procedure, you need to prepare the patient. You may need to make sure that the coagulation profile is within normal and the platelet count is higher than 50,000. An informed consent needs to be obtained from the patient, and the patient needs to be fasting. Post-procedure care will include observation and vital sign. So we're done with vascular interventions and percutaneous biopsies. Now let's talk about drainage procedures. So fluid collections are abnormal collection of fluid in a potential space in the body. They can either be transitate or exudate. They can either be sterile or infected. Effusions can be either pleural, peritoneal, or in the joints, or abscesses, for example, are a different type of fluid collections, which is basically a collection of purulent fluid contained within a wall. And they manifest clinically with fever, malaise, redness, hotness, tachycardia, and hypotension if in extreme cases a septic shock occurred. Usually treatment of an abscess is with antibiotics and drainage. Small abscess, less than, for example, 2 by 2 centimeter, can be treated conservatively. However, anything bigger than that is usually drained percutaneously or drained surgically. Here you see an example a drainage procedure of acidic fluid in which the needle drainage catheter was introduced into the peritoneal space, draining the ascites. So, like any other procedures, again, potential complications include vascular or visceral perforation, bleeding, and septicemia. So the patient usually needs to be prepared by getting a good coagulation profile values, and the platelet count should be above a certain limit depending on the risk of the procedure. 50,000 is usually a good limit. Consent about the procedure, its potential complications, and any possible alternatives, and fasting. This is an example of a drainage procedure in which a patient has a periappendiceal abscess collection. So instead of opening the patient surgically to remove the abscess or clean it, percutaneous drainage can be done using a needle that goes all the way into the abscess cavity, in this case under CT scan guidance, and then using the over-the-wire technique, a wire is advanced inside the needle all the way into the abscess cavity, followed by removal of the needle and then insertion of a drainage catheter over the wire. This is called over-the-wire technique, and we will talk about it later in the slides. So after a drainage catheter was inserted in the interventional radiology suite or in the CT scan room, the patient goes back to the floor and the drainage catheter remains in place, connected to a drainage bag for the next couple of days until all the purulent fluid is aspirated or drained. So immediately after the procedure, we need to observe the patient, make sure everything is fine. We need also to monitor the output, know if the drainage catheter is properly functioning and draining the pus and the purulent fluid from the collection or not. Sometimes we need to irrigate the catheter with saline, so inject a small amount of saline just to unblock it. Sometimes we need to further image if there are persistent symptoms. Let's say, for example, after 5 or 6 days, the patient is still having fever and the catheter is not showing any output. The bag is empty. So you might need to rescan using a CT scan or an ultrasound and see what is the status of that collection. Is it still there? Is the drain inside the catheter, or was it moved outside the catheter, by example, by mistake? So when there is minimal fluid output and there's significant clinical improvement, then it is the proper time to remove the drain. Patient symptoms improve as well as minimal output from the drainage catheter. Okay, so we talked about 3 different types of interventions: vascular, biopsies, and drainages. Now we will talk about embolization. Embolization is basically a minimally invasive method to occlude the blood supply to an organ or to different tumors or to a vascular malformation in the body or to a bleeding vessel. Why would we want to do that? We will talk about this in a second. So the image guidance that we can use is either fluoroscopy, or sometimes we can use ultrasound or CT scan. This is an example case in which we used embolization in a 45-year-old female who fell from a horse and sustained blunt trauma to the left flank. She was in hypovolemic shock on arrival to the emergency department and was resuscitated with intravenous fluid. A CT scan was done in the arterial phase that showed the kidney being pushed anteriorly by a large hematoma and active extravasation within the kidney. So the patient was rushed to the interventional radiology suite and an angiogram was done similar to the one that we saw a couple of slides earlier. However, this time it's not a normal angiogram. There's active extravasation at the lower pole of the kidney. The interventional radiologist in this case embolized using a coil. A coil is basically zumbarak in Arabic. And they closed the bleeding vessel. This is another case of a 70-year-old female who fell from down the stairs. In this example, the spleen is showing an area of active extravasation here and a perisplenic hematoma. The patient was rushed to the angio suite and the angiogram demonstrated active extravasation from the spleen, and again embolization with coils stopped the bleeding. So embolic agents are either temporary or permanent. We use temporary when we want blood supply to the organ to resume at a later stage, and we use permanent embolization agents if we want to cut the blood supply once and for all permanently. Gel foam, which is basically gelatin sponge, or a blood clot. We just take blood in a syringe out of the patient using the same catheter, wait for it until it clots, and inject it back as a temporary agent. Permanent embolization agents include coils, particles, or glue. We will have a look at those later on. So embolization can be done for elective cases or it can be done for emergency cases. We will talk about elective cases quickly here. Sometimes uterine fibroids can occur in patients, and in the proper clinical setting we can embolize them instead of opening up or doing a laparoscopic myomectomy for fibroid removal. We can embolize them using a small catheter through the right common femoral artery. A new technique that's occurring or happening now, being introduced into the market, is prostate artery embolization for benign prostatic hyperplasia. We can sometimes do gonadal vein embolization in cases of varicocele or varices. Portal vein embolization is another technique in which we close the blood vessel in the portal vein in part of the liver to try to enhance growth of the remaining part of the liver. Let's say a patient has cancer in parts of his liver, the left lobe, we can sometimes close blood flow going to the left lobe of the liver and maintain blood flow to the right lobe. And if we close that blood flow here, this part of the liver will remain inside, will remain the same in size, while that part would become larger. So later on, the surgeon can come and cut the left lobe easily when the patient has a large right lobe. A new technique that's being introduced lately is bariatric embolization. This is still an investigational technique in which the interventional radiologist closes the left gastric artery. This leads to less blood supply to the fundus of the stomach, and in that case, less secretion of the hormone ghrelin. Embolization of the left gastric leads to less blood supply of the fundus of the stomach. This is an example case, a patient with multiple uterine fibroids. She's presenting with menorrhagia, and post-embolization the fibroids slightly decrease in size, but what's more important than the decrease in size of the fibroids is the resolution or the decrease in symptoms. This is an example case. You can see that the catheter going through the right common femoral artery, going up into the iliac and up into the aorta, and then descending down into the internal iliac artery, and then you will see enhancement of the uterus as the interventionist injects contrast. This is the uterine artery, and this is enhancement of the uterus. Another case example. This is the right uterine artery, and here it is post embolization. You don't see the blush, the visceral blush, which means that the particles that were injected closed or occluded the capillary. The fifth part in our categories is interventional oncology. So there are three main pillars of oncology. Of course, the medical oncologist, the radiation oncologist who treats cancers with radiation, and you'll hear about that in our course, and then surgical oncology. A newly introduced fourth pillar is the interventional radiologist or interventional oncologist. So what do these people do? Again, they use minimally invasive procedures with lower morbidity and improved care. They can either do their procedures percutaneously or endovascular. Percutaneous meaning that through the patient's body directly, for example, direct injection of the tumor itself through the skin, or endovascular, as we have seen in previous examples, going through the common femoral artery, for example, using catheters all the way into the tumor. When it was introduced, interventional oncology was limited to palliative therapy. However, new approaches and new techniques are now approaching first-line surgical care for certain tumors. They might be as good as surgeries in certain patients and certain tumors. So there are different techniques to ablate tumors. Most and more commonly used is ablation techniques, in which the interventional radiologist applies thermal energy to destroy the cancer cells. There are different types. Radiofrequency uses electric current that induces heat, and heat kills cancer cells. Microwave ablation uses microwave, which oscillates H2O molecules and induces heat, which kills tumor. Cryoablation, in which the interventional introduces a needle. The needle has argon gas inside it that stays inside it. However, it becomes quite cold and introduces a crystal ball of ice within the tumor itself, and it destroys the cell wall. Chemical ablation, for example, using ethanol or acetic acid, causes cell dehydration and cell death. Those details are not as important, but it's a good point to understand the basic concepts. This is an example case in which the patient has, let me bring in the laser pointer here. So the patient has a renal cell carcinoma in the left kidney, and in this case the interventionist introduces a needle for cryoablation. This is during the cryoablation procedure, and then this is a follow-up CT scan that showed ablation and necrosis of the tumor cell without any evidence of enhancement and recurrence. So other than ablation, the intervention can use endovascular therapies. The principle here is to diminish the blood flow to the cancer cell, minimize blood flow and stop it. So there are different types: transarterial embolization, so basically the catheter is introduced into the artery, and then particles are injected to occlude the small vessels supplying the tumor. Sometimes these small particles are very small stuff similar to sand particles, quite small, 300 to 1,000 micrometers. These can be sometimes coated with chemotherapy. So when they go into the capillaries and occlude the capillaries, chemotherapy gets released into the tumor cell. Sometimes these particles are coated with yttrium-90, which is a radioactive material. So the radioactivity can induce cell injury at the area of the tumor. So I know we said 5 main categories. However, we can also add one more: MSK interventions. These include vertebroplasties for patients in whom vertebral body fractures are present, joint injections such as for arthrograms or for fluid aspiration, either for analysis, and sometimes even joint injections for pain management can be done. This is an example case of a vertebroplasty. This is a collapsed vertebra, and the needle, as we can see, is introduced, and then cement is injected inside the vertebral body. This kind of procedure has significant pain relief to patients, especially patients with metastatic vertebral collapse. So a cancer patient with metastasis into the vertebra, in which the vertebral body doesn't have any internal support, injection of cement can help relieve these patients' pain. This is an example arthrogram patient. So a needle was introduced into the shoulder joint, and contrast material was injected to dilate the anatomy of the shoulder joint. So we talked about the specialty of interventional radiology. We classified image-guided interventions into one of 5 main categories. Now let's select the appropriate intervention or radiology procedure for common clinical scenarios. So this is a 6-year-old boy who fell from a balcony in the first floor and was hypotensive on presentation to the emergency room. This is the CT scan that was done, and it shows a significant amount of blood within the abdomen, as well as an area of active extravasation within the liver. So an angiogram was done that demonstrated again active extravasation. There was coiling of the bleeding vessel with good results at the end, no more extravasation post coiling. So our second case includes a 58-year-old male ICU patient with an upper GI bleed. This patient has active GI bleed, so this is a contraindication to anticoagulation. He was also found to have a DVT and a pulmonary embolism, so we cannot give him anticoagulation for his DVT and for his PE. We need some sort of other kind of treatment to prevent further pulmonary embolisms from his DVT. And in this case, we can insert IVC, an inferior vena cava filter, similar to what we see here. However, it's very important to keep in mind that these filters need to be removed because they themselves can cause IVC thrombosis. If they remain for a long period of time, they can cause IVC thrombosis. So remember, I will tell you please to remember to remove the filters. All right, remove. This patient is a 67-year-old female with intermittent transient ischemic attacks. She was found to have significant carotid stenosis that's not responsive to medical management. Let's have a look at her angiogram. The angiogram demonstrated multiple areas of significant stenosis of the carotid artery. So in this case, she was treated by stenting, and as you can see, she had good results in there. This is the next case, a 35-year-old male patient with aching left scrotal pain, worse at the end of the day. On ultrasound, he was found to have varicocele. He was then planned to have an elective varicocele embolization procedure, in which the gonadal vein is embolized using coils or using different embolization material. This is an angiogram demonstrating the catheter going from the right common femoral artery up and down through the left renal vein down into the left gonadal vein. It demonstrated dilated tortuous gonadal vein. This was embolized using coils, and the patient symptoms improved. So we're done with 3 out of 5 parts. Let's have a look at the commonly used interventional radiology device. So this is one of the first devices that an interventional radiologist would use during an intravascular procedure after getting access into the artery, for example, the common femoral artery in the groin, using a needle and then inserting a wire through the needle. The needle would go out and then a vascular access sheath would go in. This acts as a port into the vessel, so that part would be inside the vessel while this part is outside the patient, and then a wire or a catheter can be easily introduced in and out from the groin. These are example stents, covered such as this one or uncovered such as that one. They come in different sizes, shapes, and different uses. This is an angioplasty balloon over the catheter. That's a catheter that goes into the diseased vessel, and once you reach the occlusion, you would inflate the balloon. These here are embolization particles that we inject into the vessels to occlude them. They're basically very small sand-like material that come in different sizes. For example, this one here is 500 to 700 micrometers. The use of particles is basically to occlude the vessels. Same for embolization coils. This is a coil, and we introduce it into the diseased artery to occlude it, or into the target artery to occlude it, using diagnostic catheters. So this catheter part remains outside the patient while that one goes into the vascular sheath all the way to the target vessel. And then we can introduce different things through the port, through the hub, either particles or coils or even just basic simple contrast material. So this is a diagnostic catheter. That's one of the main working horses of the interventional radiologist. These are different vascular access devices. This is a portacath, in which a small port device, a 2 by 2 or 2 by 3 centimeter device, is implanted into the subcutaneous tissue that can be accessed using needles, and it remains there while the catheter part goes all the way into the central circulation. So for example, when giving chemotherapy, that part would be in the subcutaneous tissue, and then the nurse would insert a needle, inject chemotherapy that goes all the way into the central circulation, and then by the end of the chemo session, she would remove or he would remove the needle. This is a permcath dialysis catheter that's used for hemodialysis. This is implanted in a subcutaneous tunnel, and that part goes all the way to the central circulation. It's relatively large catheter and can withdraw a good amount of blood for the hemodialysis machine. This is the IVC filter, similar to the one that we inserted into the patient earlier on. Remember the patient that we had to remove the IVC filter when it's not indicated anymore? This is an example filter. This is a biopsy gun, similar to what we showed earlier on. So when it's armed, the interventional radiologist reaches the target area and then fires it using a trigger mechanism. This is a similar gun that's a semi-automatic. It just gives a different advantage in comparison to the automatic gun. These are drainage catheters for abscess drainage, for example, or aseptic or pleural fluid drainage. So this is the drainage catheter itself, the upper one. It has a loop. That's why sometimes they call it a pigtail catheter. These here are different stylets that go inside the drainage catheter to give it stiffness and structure so that you can introduce it through the skin easily. Basically, what's important in this slide, the most important part is the drainage catheter itself. Okay, so we talked about commonly used interventional devices. Now, let's have a look at the steps of over-the-wire technique for percutaneous access. So, do you know who uses this kind of technique? It's not only the interventional radiologist. Cardiologists would use over-the-wire technique when they go in for cardiac catheterization. Same for ICU staff when they insert temporary dialysis catheter or central venous access. They use over-the-wire technique. Same for ER physicians. Sometimes they can use that for getting central venous access. So keep an eye, because regardless, even if you're not getting into interventional radiology, this technique is going to be useful to you. So first, you would insert the needle through the skin under image guidance, and be careful, try to avoid non-target organ. This is the skin, and this is your needle going in all the way to the target area. And then once your needle reaches the target area, you basically put in a wire and you loop it inside the target area. So after you insert your wire, you don't need the needle anymore, you can remove it. What remains is the wire going all the way from outside the patient through the skin into the target area. And then over the wire, you can introduce your drainage catheter or your hemodialysis catheter or your central line over the wire all the way until you reach your target organ. After you introduced your catheter, you can remove the wire, you don't need it anymore. So you're done. Okay, so these are the basic steps of over-the-wire technique. We are done with the outline of our lecture. Just to give a summary, so interventional radiology is a specialty of image-guided, minimally invasive interventions, relatively new in the field of medicine, and it deals with both diagnostic and therapeutic interventions. It is a rapidly expanding field, and it is seeing or encountering rapid and continuous development of new devices, new techniques, and new treatments. So, did we forget something? Maybe? Yes? Try to remember. Okay, so remember that patient that had the IVC filter? So this patient does not need it anymore. He is now on anticoagulants. His blood GI bleeding has stopped, and now it's time to remove the IVC filter. He does not need any more IVC filter type of protection. So this is the procedure here. We go through the right internal jugular vein, going all the way. The wire passes all the way to the IVC, and this is basically a dilator. Going all the way, making a space for the sheath retrieval. This is the sheath retrieval set. So it's a small, a catheter that goes over the wire, in which we will retrieve the sheath, and we will retrieve the filter through it. As you can see, it's going down through the right ventricle into the IC. And then we do a venocavogram demonstrating if there are any clots around the filter or not, demonstrating the shape and appearance of the filter itself. Afterwards, we try to snare it. A snare is a loop, similar to a rope loop. You try to catch the tip of the filter, the upper tip of the filter. You try once, you try twice, until you get it. Okay, looks like the interventionist got it. Let's see. Oops, now it slid out of it. Apparently it was projecting over the tip of the filter while it did not really catch the hook. So what do you do if at first you don't succeed? Try again. Okay, so this time it was caught. The filter is within the loop. So basically at this time, the interventionist would push down the sheath over the filter to close it apart and release it from the IVC. And then they would pull up the filter through the sheath all the way upwards. This is the filter going upwards and being retrieved. And then you would do another venocavogram to demonstrate that there are no complications and to demonstrate that the filter has been removed without any active extravasation elsewhere. These are small tributary veins of the IVC. Okay, just want to invite you to have a look at this short paper talking about the residency match of 2018. And can you guess what was the most competitive specialty? It was actually intervention. If you need any further information about interventional radiology, you can have a look at this book. It's available to all Cambridge University students via the library, public library, online public library. And I will also post a copy in the Google Classroom for you guys to have a look at. Thank you. So keep up the good work and see you in the Andrew Suite. You're more than welcome to visit us on the ground floor, the Department of Diagnostic Radiology, Interventional Radiology Unit.